Before we start, I'd like to bring you a message from Dr. Lindsay Thomas, who's a GP in Sheffield with an extended role in women's health, and she's taking part in MIMS Learning Live North on 26 November in Liverpool. She says,
I'm really looking forward to joining Dr. Olivia Hum at MIMS Learning Live North to discuss key questions in menopause. Menopause is a fast-changing environment, so we're hoping you can join us to talk through some of the key current issues, including management of the perimenopause, bleeding, new progestogen options, and when to think about testing estradiol levels.
So that sounds great. I'm really looking forward to this fireside chat between Dr. Hum and Dr. Thomas, who both have so much expertise to share. Do come and join us in Liverpool for a packed clinical learning event in a fantastic new venue. Book now at mimslearninglive.com. Hello and welcome to the Clinical Update podcast, the podcast that provides you with thought-provoking clinical learning from MIMS Learning that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning, and I'm delighted to have with me today Dr. Pipin Singh, who's a regular interviewee on these podcasts. Welcome, Pipin.
Hi, Pat. Thank you for having me back.
Oh, not at all. And Pipin is going to talk with us today about lower urinary tract symptoms in men, which are a common presentation in primary care, and he's going to provide us with some insights on diagnosis, investigation and management. So, first of all, Pip, what's the scale of the problem and what's the potential impact on patients?
Yeah, sure, Pat. So the severity and prevalence of lower urinary tract symptoms in men increases as men get older. And it's estimated that as many as 30% of men older than 65 will be troubled by one or more lower urinary tract symptoms, which will have a significant impact on their quality of life. The prevalence of storage symptoms increases from about 3% in men aged 40 to 44 to around 42% in men aged 75 years or older. So quite a big increase from 40 to 75, with the prevalence of urge incontinence increasing from 0.7% in men around 50 to 59 to about 3.5% in men aged 70 years or older. So it will have a huge impact on people's quality of life and confidence and their abilities to, get out and about and so forth. So it can be quite restrictive. You'll have about 1/3 of men will develop urinary tract outflow symptoms, of which the principal underlying cause is generally benign prostatic enlargement, so BPE, as people get again older above 65. And once symptoms arise, the progress can be very variable and unpredictable, with about 1/3 of patients improving, 1/3 remaining stable, and 1/3 of patients deteriorating. So it's quite a variable set of symptoms which can have an impact on people's quality of life. And a lot of it will be determined by whether people present, when they present, and so forth, and levels of concern around certain conditions. And we know that people often, men, as they get older, do worry about prostate cancer. And obviously, that's quite a big thing in the press at the moment as well. So a lot of these things will come into play when determining the prevalence, because a lot of it will be determined by how often people are presenting and the factors that allow people to present as well.
So if you talk me through a typical consultation for these type of symptoms, what would the patient usually say to you?
Sure, yeah. So, LUTS consultations in men can be very complex, as the differential is often very broad. And this is something that often will require quite a few consultations. I'm forever telling my registrars this: don't feel like you have to try and get through this in a single 10 to 15 minute appointment, because it's almost near on impossible. You are going to need a couple of consultations in order to make a provisional diagnosis and determine whether it could be an exacerbation of an underlying problem that they may have already consulted for, whether that be 5 years ago, 10 years ago, or maybe a brand new problem, for example. So you may get some information in the booking notes when reception book the patient in, or when the patient books themselves in via the various online systems. They might write something in the notes to say why they're booking in. And that'll allow you to have a look and see, have they consulted with this problem before? Using the clinical system, I always say make sure you use the clinical system well. Have they presented with this particular problem before? Can you search for something like urinary in the text search just to see, have they been in about it 10 years ago, 15 years ago? Is it brand new? Because often if you ask patients, they may forget that they've been in about a particular set of symptoms If they have been in about it before, was the situation managed in primary care? Did we come up with a diagnosis in primary care? Was it yourself that did it, for example, if you've been in a practice for a long time? And if so, what was the treatment that you provided? Was a potential referral needed? So this is what I call sort of pre-consultation preparation part, making sure you've had a good look through the record if you know why the patient's coming in, to see if they've been in about that before, and may it be relevant to the reason that they're coming in this time as well. Have a look at again, with any pre-consultation preparation, have a look and see what medications are they taking. Have they had any relevant investigations to that particular problem? Is there anything available in System 1 or EMIS? And as I've mentioned, you can search for keywords via the text search there. So once the patient does come in and you've done that bit of pre-consultation preparation, let the patient talk freely about their symptoms. And it's important to explore the impact of those symptoms on quality of life. How is it impacting them day to day? What's it stopping them doing? Is it impacting on work life? Is it impacting on college life, uni life? Obviously, depending on how old the patient is that's coming in to see you. And obviously, each case will be different in that respect as well.
So do you find that there are any questions that you can ask that really help to elicit symptoms in this type of consultation?
Sure, yes. So the questions will be very much geared around what the patient obviously presents with in that kind of opening minute, really. And you're thinking about, or I'm always particularly thinking about, neurological causes of lower urinary tract symptoms versus non-neurological causes, because as we know, we need to keep that diagnostic net cast wide, because as I mentioned earlier, it's potentially a very, very broad differential diagnosis, a set of diagnoses that the patient could have depending on what they're presenting with. So for me, it's finding out about the timing of the symptoms. Is it an acute problem or a chronic problem? Because that's automatically going to take you down a potentially different management plan. If it's a chronic problem, are they persistent symptoms? Are they progressive symptoms? Because again, that's making you a bit more concerned if something is worsening over time, rather than something that maybe started 6 months ago, but actually has got better, but the patient just wants some reassurance. My questions will be very much guided around things like what we call voiding symptoms, filling symptoms, or also known as storage symptoms. So voiding will be things like poor stream, terminal dribbling. Storage symptoms will be very much around dysuria, frequency, urgency. Then you've got red flag symptoms to think about. So weight loss, back pain, night sweats, hematuria, any fevers, particularly if it's an acute presentation. Is there any associated vomiting? It might be relevant to take a sexual history as well. So sensitively signposting to the patient that you may need to ask some questions around this, which may allow you to determine as to whether there's a certain STI that could be causing the symptoms that the patient's presenting with. Thinking about sort of non-neurological causes, and as I said, keeping that diagnostic net cast wide, make sure to think about excessive, things like diabetes, so inquiring about excessive thirst, fatigue. What's a patient's fluid intake like? How much caffeine do they drink? Are they taking any over-the-counter medications, any purchase medications over the internet, or are they engaging in any recreational drugs as well? There is a well-recognised link now between ketamine abuse and lower urinary tract symptoms, which can affect women as well, but I know we're specifically talking about men, but it's worth inquiring about that if you think that may be relevant. As we know, they can cause, or ketamine abuse can cause urinary frequency, nocturia, urgency, incontinence, cystitis as type symptoms as well, which may require further investigations via urology. And also think about asking about alcohol intake, and what other things that might be relevant may include neurological symptoms as well. And again, as I say, keeping that diagnostic net cast wide for non-neurological causes of lower urinary tract symptoms. And as all GPs will know, and associated healthcare colleagues, asking about sort of our patients' ideas, concerns, what were they hoping for from that particular consultation, and as we've mentioned, impact on quality of life as well.
So it sounds like with that wide range of possible causes that there would be no single assessment tool that you could use, but are there assessment tools that are helpful to cover off some of those possible causes?
Yeah, sure. So I suppose there are a couple of tools that I would still use. I mean, as I know there's a lot of questions there that we've covered, but I would also be thinking about using a bladder diary for 3 days. Just gives you an idea of a patient's fluid intake and output. And that's something you can just find on the internet if you just stick it in a search engine, and you can print that off and give it to a patient to complete for you. It just gives you a good idea of how much actually are they drinking fluid-wise, what is coming out, and the timings of which it's coming out. So it gives you a bit of an idea of where they're at within what's going in, what's coming out. And things like an international prostate symptom score as well, also known as an IPSS, can be very helpful at allowing you to decide, has someone got more of a voiding picture here, or have they got more of a storage pattern here, or is it a combination of a set of voiding symptoms and storage symptoms? Even though you've taken the history, it just gives you that objective feel for where things are at. And the beauty of the IPSS as well is that it allows patients to grade whether they would feel satisfied if they left their condition untreated, or dissatisfied, and they score themselves there, which can give you a really good idea of actually how they're feeling about their quality of life with regards to the symptoms that they're experiencing. Plus, it's a good baseline objective tool as well. So if you do make an intervention in primary care and you're reviewing that intervention in whatever time frame you decide, you can then complete an IPSS score again and see, has anything improved? Has it stayed the same, or even has it worsened? And you can also show that to the patient as well. You can look at the previous score and then compare and contrast the second score as well to see that. And the patient can see that, and I think they find that quite helpful as well, because often they may not remember what they told you from 6 months ago or even 3 years ago. To have that objective tool scanned into the notes that you can pull up and show them, I do personally find very, very useful.
And interesting to see that it asks them, would they be happy to just go with watchful waiting and just cope with symptoms rather than necessarily being treated?
Yes.
That's a good aspect of it. And you mentioned red flags there. What kind of red flags are you looking out for? Obviously, cancer would be one of them, but are there other things as well?
I'm always, as I said, thinking in terms of that neurological versus non-neurological cause, and your differentials are obviously going to be dependent on the patient's age, the chronicity of the symptoms, what you found in the history and or your examination as well. So in terms of neurological causes, I'm thinking, is this, as I've said, acute versus chronic? And with acute problems, I'm thinking, could this be a UTI? Could this be something like an uncomplicated UTI versus a complicated UTI? Could this be an STI? Could this be like a presentation of prostatitis? Could they have some renal calculi that could be causing the problem for acute presentations? If it's a more chronic picture, again, you could still be thinking around STIs, prostatitis, but that's when I'm starting to get more into that. Could it be a more BPE type picture? Could it be a presentation of overactive bladder? Could it be now something like a bladder cancer, a prostate cancer, a renal cancer? Could they have something like retention with overflow? And they're the sort of more pathological things that I'll be thinking of. But, in terms of basic things, and as I mentioned, when taking your sort of history around fluid intake, you do want to sort of think about things like excess caffeine, excess alcohol as well, because it could be something as simple as a patient's drinking 12 cups of coffee a day, loads of energy drinks and that sort of thing, which are loaded with caffeine, which might need some simple tweaks. Alcohol excess may be a different approach you might need to take depending on what's uncovered when you're exploring the alcohol, and that might be slightly more complicated. But again, might be nothing related to any underlying pathology related to the urinary tract, but might be more to do with lifestyle. And non-neurological causes, I'll be thinking about things like diabetes, certain medications as well, timings of certain things like diuretics, for example, frusemide and so forth. Is the patient taking, if they're on frusemide, are they taking it late at night, which could be contributing to getting up in the middle of the night to open their bladder? So again, it might not be anything to do with a urological cause. Neurological causes as well, thinking about neurogenic bladder, which could be caused by something like multiple sclerosis. And going back to the acute causes, could this be a presentation if someone's got urinary symptoms or incontinence or any saddle anesthesia or associated neurological conditions? Could this be a presentation of Cauda-Equina syndrome as well? So again, not to miss those non-neurological causes, which again wouldn't be anything related to specific pathology of the urinary tract itself. And as I've mentioned, ketamine bladder, that's something to think about. But yourselves have been running a big cancer campaign this year, and cancer can most definitely present with lower urinary tract symptoms. Although I would say symptoms don't necessarily correlate well, and that can be the tricky part of lower urinary tract symptoms in men. But yes, of course, bladder cancer can present with hematuria, recurrent UTIs, palpable masses in the abdomen, which a patient may have felt themselves. Prostate cancer can present with night sweats, weight loss, back pain, and all the other lower urinary tract symptoms like voiding symptoms such as the terminal dribbling I've mentioned, the slow to start, the poor stream. But again, with prostate cancer, you may not get any symptoms at all. So it can be very, very tricky. Renal cancers can present with loin fullness, loin pain, again, recurrent UTIs, hematuria. And not to forget things like penile cancers, which can present with lesions at the glands, meatal lesions, which may cause some obstructive symptoms as well. And then there's other sort of rarer malignancies to think about, like urethral malignancy and ureteric malignancies, which again may present with nothing, or they may have some of the symptoms that I've mentioned there, like hematuria. There may be some voiding symptoms or some storage symptoms as well. But those sort of latter two that I've mentioned are particularly rare. And you may not even see one in your career, to be honest.
Right. But I guess there's always a possibility that you could. So you've got to have all these things on your radar.
You do. That's the purpose of red flags, isn't it, Pat? At the end of the day, as GPs, our role is to identify red flag symptoms and act on those. Now, those red flag symptoms, one red flag symptoms might mean it could be 4 or 5 possible cancers that could be linked to that red flag symptom. But our role is largely to explore that red flag symptom and investigate accordingly, refer onward, and then our secondary care colleagues would do the necessaries to work out potentially which type of malignancy. If it's a malignancy that you're thinking, obviously there's red flags for other conditions which aren't malignancy, but it's our secondary care colleagues who are likely to be doing more sort of invasive tests to work out what the problem could be for that red flag symptom.
Great. And you've mentioned investigations. That leads us on nicely. So what kind of investigations would you be looking at?
Yeah, so I think, Pat, just before I move on to investigations, I probably should just talk a little bit about examination. Moving on from my history, I would always think about examination first before moving on to my investigations. And that, with acute symptoms, that might require basic observations, which will include sort of a temperature, palpating for any flank tenderness, suprapubic tenderness, checking the patient's pulse, checking the patient's blood pressure, obviously making sure if you're thinking along an acute, is it a UTI, complicated versus uncomplicated? May you have someone with a pyelonephritis? Do they need to be admitted there and then? So we need a pulse, blood pressure, temperature, so the basics there. If a patient's presenting with sort of more chronic symptoms, I'll be thinking about still palpating the bladder just to see could there be a degree of retention there? Is there any pain? Are they distended? And then the possibility of needing to do a digital rectal examination as well. Now, there's a lot of questions around whether digital rectal examination is necessary at the moment. I think more in the context of a patient's got a raised PSA, do you then need to go on to do a DRE? But also the value of the DRE has been questioned recently by our urological colleagues. And it has been questioned for a number of years, but I think it's become more into the mainstream recently about, is it really needed? Because if someone has got prostate cancer, is the PR going, or is the DRE going to pick this up? Now, my personal view on that, and others may feel differently, but my personal view on that is, I do think I personally find it quite helpful to assess the size of the prostate to allow me to determine whether a patient's symptoms could be linked to BPE versus something else. And also I do find it helpful to know, is it a smooth prostate? Is it hard? Is it craggy? Is it a nodule? If you're thinking prostatitis, does it feel particularly tender compared to a DRE, which is a standard DRE, which yes, will be uncomfortable, but prostatitis patients, if you touch the prostate gland, can be in extreme pain compared to the usual discomfort that they might get or expect to get with a DRE. So I do think there's still some value in a DRE. Alongside also, we know that constipation can lead to urinary tract symptoms. So it allows us maybe to assess, is the patient constipated as well. So that will be my sort of approach to an examination. So it'll be a focused examination based on what you found in the history. Is it an acute history? Is it a chronic history? And then, like with anything, you would go from there and tailor your examination to the answers that you've received in your data gathering. And then moving on to the investigations that you were just asking about there, Pat. Again, like with anything, you're guided by your history. It might be that you don't need to do any investigations. You might have identified that person's drinking all that coffee or all those energy drinks and they're in their 30s and you've not identified any red flags and they've got largely storage symptoms, emergency frequency. So you may agree just to sort of trial off certain reduced caffeine intake and review and see where they're at. And actually that might be all that's needed. So it's important to keep that wait and watch management aspect in your armory as well, without intervening with drugs all the time, which we know can cause harm. So think about that wait and watch approach. And if you are investigating, then again, it will depend on what you found in your history and your examination. But things to be thinking about might be a sort of basic full blood count, looking, say, for example, at raised platelets. If you're suspecting a malignancy, could there be anemia of chronic disease there? All the things that we look for in a full blood count. So renal function may be very important, particularly if you think they've got chronic retention, for example, and that might be leading to a hydronephrosis, which might be causing renal impairment. You might think about CRP, you might be thinking about an HbA1c if you suspect that the symptoms might be linked to diabetes. I'd also be then consider, depending again on the age, the history, what the patient's actually presented with, I'll be thinking about the PSA, and that might require some counselling around what it is and in terms of its accuracy, because we all know that PSA is not a screening tool as such, and we know it comes with errors. So we know that if it's positive, it doesn't necessarily mean someone's got prostate cancer. If it's negative, it doesn't necessarily exclude prostate cancer. So its sensitivity and its specificity is quite low, which is why it's not being used as a screening tool to pick up prostate cancer. I know there's been a little bit in the press around screening for prostate cancer this last few days as well, and we're still not quite there with screening tests yet, although we are making a move towards that. So I do tend to explain to patients that, look, this isn't a screening test, and if it is positive, it may well have other causes, and if it's negative, it doesn't exclude cancer. So this is why it is difficult with men's lower urinary tract symptoms, particularly if they're in that older age group, above 50 particularly. You're using, if they do decide they want a PSA, you are using it as a piece of the jigsaw in combination with your history, any red flags, your DRE, and then your PSA. Although we've moved on in the sense that previously PSA, if it was raised, you'd be likely to be straight to biopsy. We do now have an extra step in that pathway, and that patients can go direct to MRI. So there have been big advances there, which might mean that they don't need to have a biopsy, because we knew biopsies did come with quite a lot of potentially complicated side effects, with problems with erections afterwards, incontinence. There are issues or potential for issues with biopsy, whereas we know that an MRI is a reasonably safe test, and the MRIs can pick up hotspots, and then the biopsies can be targeted at those hotspots. And if the MRI doesn't find anything, then you can probably be safely discharged with maybe monitoring of your PSA on a 6-monthly basis, or whatever the urologist decide is appropriate. So things have moved on recently with recent trials, and I suspect the work that's being done to look at screening is looking largely around MRIs and PSAs at the moment. So it'll be interesting to see where things go.
Yeah, it's an evolving picture, and as you say, there's been bits and pieces in the media about it, but we'll just have to wait and see what happens with that one.
That's right, absolutely. And I think it's important not to get too overwhelmed by the publicity and almost the sort of public demand for a screening test, isn't it? Because at the end of the day, it's still the science that dictates what happens. So we have to make sure we've got the right tools in place for the screening to be allowed to happen, because screening is there for a reason. And if it's not there, it means we haven't got the right tests, really, because we know that some of these tests do come with harm. So we need to be very, very careful about that. Also is that it's important that it's not checked when patients have an active UTI or a suspected UTI. I see it very often. A PSA is requested by somebody when they're also suspecting a UTI. Well, that isn't ideal, because if they've got a UTI, the PSA is going to be potentially raised, and then all of a sudden you've got a falsely elevated PSA, which can create quite a lot of anxiety for patients, and then for us in terms of knowing what to do, because then we have to wait for the UTI to settle and repeat the PSA. And sat in the middle of all this is a patient who's then waiting for a test result maybe 6 weeks later, and they've got that uncertainty around them. So if you're suspecting a UTI, wait for your culture to come back. Maybe think about waiting for a response to the antibiotic that you may have prescribed, then make a decision about whether a PSA is appropriate later on down the line, whether that be in 2 to 3 weeks when you followed them up. Don't be doing a PSA at the same time that you're then treating for a UTI. And that's not an uncommon thing, I would say. I think the message is more out there than it ever was, but I still do see that occasionally happening from time to time. And if you are doing a PSA, just make sure that there's a few other things that can cause it to be elevated, like recent ejaculation within 48 hours. So advising patients about that. But also, it used to be thought that the DRE could put the PSA up as well, and it, just with that examination. But I think the school of thought is more so that it's less likely to do so. That is something also just to kind of bear in mind, but you can probably do the PSA after the DRE. I think, as I said, the school of thought's moved over that the DRE doesn't necessarily affect the PSA too much anymore.
Now, you have just kindly updated a module for us on benign prostatic hyperplasia, which I learnt from looking at that module is a histological diagnosis. And so benign prostatic enlargement is perhaps the more correct term to use when just talking about enlarged prostate. And that, presumably BPE, is a major cause of lower urinary tract symptoms. Is it the most likely cause?
Depends on the age, Pat. I mean, if I was seeing a 20-year-old with lower urinary tract symptoms, I wouldn't be thinking about BPE. If I'm seeing a 40-year-old and above, then I'm more likely to be thinking about BPE. And if they're over 50, yes, I am. It's definitely going to be up there. But as I've said earlier, keep that diagnostic net cast wide. Don't just assume every 50-year-old male that comes in with lower urinary tract symptoms has BPE. I know no healthcare professional will be doing that, but it's important, as I say, to ask all those questions around other causes as well, because yes, BPE is a big cause. It's not the only cause, as we've talked a lot about earlier on.
So then my next question was about management options for primary care.
Yeah, so management, of course, will depend on the differential diagnosis. So that might range all the way through from an acute admission if the patient's presenting with something like pyelonephritis, or they've got an acute prostatitis and they're systemically unwell. They may have an AKI, for example, if they've come in acute urinary retention. So again, if they're in retention, you're going to be admitting them anyway. You're not going to be waiting to do bloods and so forth. So there's all the way through from acute admission to, the more chronic presenting patients where you may be trialing some different medications, depending on, again, on what you think the differential is. And if there's no red flags, you may well be happy to manage these lower urinary tract symptoms in primary care. And as I've mentioned as well earlier, the wait and watch approach, you might identify it's not anything to do with an underlying urinary tract pathology. It might be something as straightforward as that they're having far too much caffeine and you need to reduce that. But if you are going to be managing someone in primary care with medications, it will depend on what it is. You're going to be thinking in terms of urological and non-urological causes. And I'm going to be thinking around lifestyle to discuss. So lifestyle factors into so many things, doesn't it, Pat? And, always thinking about weight, caffeine, alcohol reduction. If you're worried about someone's admitted to ketamine use, you're going to have a discussion around that. And it's not going to be an easy thing to be able to get people to stop, but may need to involve local drug and alcohol services. If you think someone's got an STI, then you may well be referring to sexual health services. And you might treat something in primary care like chlamydia, but you're likely to be referring on for that partner notification. And if it's something more complicated like gonorrhea, etc., you're going to be referring on. Things like BPE, yes, we are going to be starting some medication if we suspect BPE. So that's going to be, again, coming from your history, your examination, which includes your DRE, a negative PSA perhaps, and thinking about starting something like tamsulosin, some counselling around that to the patient about the risk of postural drop and symptoms of orthostatic hypotension within the first few days. And I will be reviewing that patient generally within 4 weeks to see how they're responding to that tamsulosin. And if they're not responding and nothing's changed in the story, they've developed no new red flags, and you're happy this is still likely to be a BPE picture, then I'll be adding in something like finasteride, counselling them again on that and reviewing them in 3 months, because we know it can take 3 months for finasteride to have an impact. And at these intervals, I'll probably be doing that IPSS again. I talked a little bit about that earlier, and getting that baseline score, and then repeat that score, because then again, it's that objective evidence. How are you responding? Because the patient might say they're not responding actually when you ask them, but when you do the IPSS score, you say, actually, look, you have dropped from 14 to 12. So there has been, although it may not feel like it, objectively, there's a bit of a subtle improvement there, which sometimes patients might think, oh yeah, actually I have improved, or whatever, and it gives you an idea that that medication is doing what you wanted it to do. Now, if you suspected something like a detrusor overactivity, they've got more storage symptoms, that dysuria, frequency, nocturia, you've excluded a UTI, you're happy there's nothing else going on, and you've felt that this is more of an irritable bladder, then you might be starting to think about something more like an anticholinergic type medication. So do you want to start something like oxybutynin or solifenacin? And again, you're going to be counselling them around those anticholinergic side effects, and then potentially reviewing them in 4 weeks' time. Well, review again, not potentially, I keep saying potentially, but no, we'll be reviewing them in 4 weeks' time and seeing how they've responded to those medications. But just being, again, cautious with the person that you're starting the medication on, the degree of frailty, perhaps, if there's any polypharmacy, because we know some of these medicines, particularly anticholinergics, do have an anticholinergic burden that we do need to be aware of. And then you've got, obviously, your cancers, you suspect a cancer going down a fast track. If you're thinking something like kidney stones, you're sending them to urology. If you're worried about a neurological problem, you're then going to go down a different arm altogether and deal with the neurological problem as you normally would.
I was left intrigued from reading that review. Like, at what point what's the sort of threshold for sending somebody for sort of flow assessment in secondary care and that kind of thing?
Referring would be largely around, again, it comes back to that acute. Is it acute? Is it chronic? If it's chronic and you're trying medications, normally it'll be a failure to respond to treatment. So if I'm happy it's or likely to be BP, but they've not responded to that combination, tamsulosin, finasteride, after 3 months, that's the point, and the patient doesn't feel like they're improving, their quality of life is still quite poor, that's the point I'll be saying, look, I think we probably need to refer you on here to have some further investigations, and then I'll let urology take over at that point. So generally treatment failure, and the same applies to detrusor overactivity. If I'm starting some medication, they've not responded, I might try another one, and then again, you keep checking in on that red flag, making sure there's no deteriorating picture, nothing new's cropped in. If you start someone on solifenacin and then 3 weeks later they get hematuria, and you've excluded an infection, I'm not going to be saying, let's sit tight for another 6 weeks and see how things go. It's going to be, actually, you've developed a red flag, we need to act on that and treat that separately. So it's going to be largely a failure to respond to treatment after maybe a couple of different types of medication, assuming nothing new has crept into the mix.
And is there a patient or typical case study that you could talk about from this area?
Sure, yeah. I mean, this is something I see very commonly, and I know a lot of my male colleagues will probably do so as well. There probably is a bit of a split, I suspect, between my male colleagues and my female colleagues as to how many lower urinary tract symptoms in men do present. A typical case study for me, I've actually just picked one person I saw a few weeks ago, which is not an uncommon situation. So there's a 61-year-old man who presented requesting a PSA, quite a common consultation, following a few of his friends having recently been diagnosed with prostate cancer, and a lot of the media coverage around prostate cancer at the moment with some celebrities having recently been diagnosed. On further questioning, he reported symptoms of urgency, struggling to pass urine intermittently, and those, he hadn't really been too troubled by them, and they'd started about 6 months ago, but they have got slightly worse when I kind of probed a bit further. And on exploration of red flags, there'd been no concerning symptoms such as hematuria, back pain, weight loss, night sweats, anything like that. So I explored the impact of the symptoms on his quality of life. And although he said he'd been managing okay, he did say he was getting a bit more frustrating with longer car journeys. Air travel had been a bit of an issue, needing to get up and back and forth for flights. They weren't troubling him too much at work, and this particular person worked as an accountant. Just to put it into some context, he took no medication, he had no significant past medical history. He reported not being a smoker, he enjoyed about 3 to 4 glasses of red wine at the weekends, and drinking around 3 to 4 cups of coffee a day, and happily married with kids. So nothing too out of the ordinary in the background. But caffeine was something and the wine just maybe something to hang on to a little bit, because it might be that might need to be looked at and discussed. So he'd not really, as I said, been troubled too much, but sort of symptoms he felt had deteriorated. But when I looked back, actually, I said he didn't have any consultations recently, but actually when I looked back as far as 2014, he did come in and funnily enough had seen myself actually, and he'd had no recollection of that. And then we did have a look at the consultation together, which said, oh yes, I do vaguely sort of recall that. But he didn't have any particular concerning symptoms at the time, but he did request a PSA. But he went on to, I think I'd done a digital rectal examination, his prostate felt okay. And it's because his symptoms were mild, we discussed a few things and he adopted a sort of agreed on a sort of wait and watch approach at that time. I did do an IPSS score with him and scanned that in, and he was scoring around 9, which is mild symptoms for an IPSS. So for this particular type of presentation, I discussed what we would do next, and I examined his abdomen, couldn't feel a bladder. I felt his prostate with consent, and he did have quite a significantly enlarged prostate gland, which was quite helpful for me to actually feel, because I could also compare and contrast that to the previous examination I'd done. I did an IPSS score with him, which was 18, so it significantly increased from the last time, and it was largely voiding symptoms with minimal storage symptoms. And then again, we looked at those 2 scores together. I dipped his urine as a standard check. I forgot to mention that in the investigation section when we were talking about that earlier, but urine dip would be part of a normal workup, and that was normal. There was no blood, no protein, no leukocytes, nothing to suggest an acute infection. There was no glucose either. And I arranged some basic blood tests, some of which I'd discussed earlier, and counseled them a little bit about PSA. Discussed what I thought might be going on and what the possible options might be. And at that point, I felt like I was happy because of his IPSS score of 18. The voiding symptoms that he was coming with, suggesting an obstructive uropathy. And again, talking about the pieces of the jigsaw, the digital rectal examination showing an enlarged prostate, combining all of that together with his age, I was happy to say this is likely to be benign prostatic enlargement that are causing the symptoms that you've come in with. So we discussed the options, we talked about his wine a little bit, talked about coffee, and I said, well, why don't we agree on reducing your red wine a touch, reducing your coffee a touch, or switching to decaffeinated, whichever you wish. And then what I'll do is I'll review in 4 weeks when all of your results are back, i.e. the PSA, the bloods, and then we can see if anything's improved with simple intervention. So it might be that you don't actually need to start any medications, because we know these medicines, as I've mentioned, come with side effects, so we've got to be a bit careful about that. So in my simple tweaks might be needed. Obviously the caveat being if the PSA is up or there's any abnormality in the bloods, we might need to change tact altogether. So I said that I'd be in touch with him if the results did show any abnormality, and the results obviously will be available on his NHS app if you wanted to check those. And I said, well, why don't you also complete an IPSS score for me the day before the appointment, and then bring it in with you when you come to see me in 4 weeks. So printed in one off, gave it to him and said, make sure you do, very importantly, you complete it the day before, not any sooner than that. So his bloods were normal, and at review reported to have reducing his alcohol and his caffeine, which had actually made a little bit of a difference. And he'd done his IPSS and it dropped his score to 16. So not massive improvement, but a little bit of an improvement to the point where he could see that. And that probably was down to just having reduced the caffeine slightly, and his sort of frequency had improved because of the caffeine reduction. So I was quite pleased with that outcome. I'm always happy when people make lifestyle changes and things improve rather than me having to intervene with medicines. I did explain to him that he's got no red flags. Examination apart from the enlarged prostate otherwise was okay, and reassured him again about that, the cancer and particularly a normal PSA. He did, however, decide he wanted to try a course of tamsulosin after I spoke to him, because his symptoms hadn't improved enough with the lifestyle tweaks. I said, fair enough. I mean, at the end of the day, those symptoms aren't going to shrink your prostate gland down. So I started him on the tamsulosin, counselled him around the adverse drug reactions, and said, let's see you again in 4 weeks. And same applies with the IPSS completed the day before. And when I reviewed him 4 weeks later, his IPSS was down to 12. So massive improvement. He felt better. His quality of life had improved, and he'd got no side effects, and he wanted to stay on them. So I added the tamsulosin. So I added it to repeat prescription, set a medication review date for 12 months, reinforce those red flags. Again, really, really important to tell patients, look, if anything deteriorates, come back, or anything new develops that you're not happy with, get back to us. We went from there. So that was someone who left happy with medication and a few lifestyle tweaks as well. So I felt happy about that consultation.
Oh, that's really interesting to hear the outcome as well, to hear the case over time and what happened. So finally, to sum up, are there any sort of key messages you'd like to pass on to GPs? I
mean, I think that case somewhat hopefully goes somewhat towards explaining also how these consultations can't be dealt with quickly. You know, this required, I would say, this was around 8 to 12 weeks before we came to an answer of whether he'd got better or not. So 3 months is quite a reasonably long time. It couldn't all be dealt with in one consultation. You have to assess responses to interventions. But key points for me are, please don't forget simple things like caffeine, alcohol, because simple tweaks might make all the difference. Keep that diagnostic net cast wide. Don't just assume everyone who's coming in with LUTS at a certain age have got BPE. Think about STIs, think about ketamine use, particularly in that younger group of patients. Although they can apply to any age group, but more likely to be applicable in younger age groups. So don't forget to ask about them. I have seen STIs missed in patients presenting with LUTS who've been put down to other things. So make sure to inquire and take a good sexual history if appropriate. Don't forget to examine the abdomen for a palpable bladder. I have seen retention missed as well. So I'm always thinking, could this be retention? And make sure to pop a hand on that bladder. Awareness of red flag symptoms, your key red flag symptoms to ask about. Also, non-visible hematuria, do you have protocols in place? I've not really mentioned a non-visible hematuria, but obviously when we do that dipstick, is there any blood? And actually, do we need to make sure that blood is followed up if there is blood and there's a negative MSU? What point are you reviewing them? How are you reviewing them? How are the patients handing the urines back in? If they are handing them back in, who are they handing them to? Are you being notified of the fact they're being handed in as well? And I know every surgery will differ in how they approach this, so just make sure your in-house protocols for managing non-visible hematuria are robust. And if they have got persistent non-visible hematuria, there'll be a protocol that all GPs and my healthcare colleagues will know that they have to follow a certain approach to non-visible hematuria, and that's a whole separate topic in itself. Continuity, I would say, is critical. I know continuity is tricky for a lot of practices, but if you can maintain continuity, I would say do your utmost best to do that, because as I've just outlined, some of these consultations require 3 or 4 consultations to reach a conclusion, and there's nothing better than the same GP reviewing that medication that's been started. And as we know, there's nothing worse than having to pick up a review for someone else who's done a lot already before you, and then you're having to pick it all up again and almost start from scratch. And that's not only frustrating for the doctor, it's incredibly frustrating for the patients who then have to repeat the same story time and time again. So try and maintain continuity where able. And as I've just outlined in my case there, I was the person that saw him, assessed him, examined him, started the medication, reviewed him. So I knew what I'd done all the way throughout that patient's journey, which made life just so much easier for both of us. Good coding in the notes. If you are coding if you've examined them, you've diagnosed BP and you're not referring them, don't be afraid to put BP in the notes with some free text found on DRE. Voiding symptoms present, DRE shows enlarged prostate, IPSS score this in the free text, because the coding is important, because then if they are presenting 4, 5, 6, 7, however many years, months later, whatever it is, if they've been in before, you can see that they've been in before, and you can see what the outcomes were without having to scroll back through reams and reams of notes, which might take some time. Make sure you follow up patients. Don't just start the medications and not see them. It's important to know, are they having side effects? Are they managing well with those medications? Are they improving? If they are improving, we're putting them on repeat prescription and setting time frames for medication reviews. And just caution with anticholinergic burden, because we know a lot of this cohort of patients presenting to us with lower urinary tract symptoms are going to be older. As I've outlined in my opening statements of this podcast, we know that the over 65s are really troubled by lower urinary tract symptoms, which might turn out to be more detrusor activity than BPE. You might be thinking more about anticholinergics, and we know that they do come with side effects. So just be aware of that anticholinergic burden as well. And there's lots of audit ideas out there for LUTS, PSAs, looking at these medicines. Are they reviewed? What's happening with them once they're put on repeat prescription? Non-visible hematuria, how is that followed up? So there could be some good quality improvement projects in there for your GP registrars, F2s or medical students as well.
Well, thank you so much for joining me today. We'll look forward to having you back on the podcast soon.
Thank you, Pat. That's my pleasure. Thank you very much.
Don't forget, you can claim CPD certification for listening to this podcast. Simply head over to the version of this podcast on the MIMS Learning website. You've been listening to the Clinical Update podcast produced by Jude Owen. Tune in next week for a discussion episode featuring our medical editors. Thanks for listening, and see you next week.